Okay, we'll go ahead and get started with today's AMSSM Sports Ultrasound Case Series presentation. I have the pleasure of introducing Dr. Shane Geffe. He's a board certified and family medicine trained chief academic fellow currently at Emory University. His main clinical interest is concussion and sports cardiology, as well as sports ultrasound, obviously, from his presentation today. He is originally from Chicago, Illinois, but also considers Florida home. And today he's going to be giving us a presentation on a Lisfranc sprain injury.
All right. Hello, everybody. Thanks for having me. Love the series, and I want to keep paying attention to what you guys are doing. I love the educational aspect, and you know, always use ultrasound in my day-to-day clinic, obviously. And sometimes you come across cases that are diagnosed with ultrasound that might otherwise be missed. So today I'm going to present a Lisfranc injury that was picked up on ultrasound and go over the regional anatomy and my approach to scanning. Briefly, the case was a 16-year-old female. She came to me about 2.5 weeks after she was diagnosed with an ankle sprain. I believe she saw another sports medicine specialist, took plain films, and thought it was a lateral ankle sprain. It was a high velocity collision, and she said that she was having a lot of midfoot pain rather than the lateral ankle sprain, and it was a non-characteristic mechanism. She said that the lateral part of her foot smacked the dashboard. She was restrained, but was still having a lot of trouble bearing weight 2.5 weeks later. And then she came to me as sort of a second opinion and to see, did we need to do further imaging, for example? I think, like a lot of patients, mom requested MRI. And the clinical relevance, a lot of us are familiar with the clinical relevance of a Lisfranc injury, as well as the standard mechanism of injury, where you have the axial loading of the metatarsals on a plantar flex foot with midfoot pain, cuneiform pain. This was different, though. This was not the standard mechanism of injury. And so I was not initially thinking about the tarsal bones involved here. And the reason I wanted to present this one is because a lot of times these can go missed, and you help yourself out by getting certain views on x-rays to start with. I'm going to argue the case that you can help yourself out by scanning this area with ultrasound if available. And a lot of the time these injuries become unstable and are a very important stabilizing ligament in the midfoot. So when diagnosed, we have to always consider consulting with our orthopedic surgery colleagues. This is a list of things that I think about scanning. If I want to do a comprehensive scan, then I'm going to think about this list. But of course, if it's only medial-sided pain, then I'll kind of abbreviate this in my mind. We're not going to look at all of these today. Specifically, we're going to look more at the musculoskeletal and avoid the avoid the nerve discussion here. So an overview of my protocol is the midfoot and ankle. And for the bones, I do assess the base of the fifth metatarsal, typically the talar dome, the tibio-talar joint. If there is a concern for a specific fracture in a phalanx or a metatarsal, then I do like to utilize ultrasound, but oftentimes my patients come to me already with plain films, and so that might not be necessary. As far as the ligaments go, the Lisfranc, of course, I usually do the ATFL and CFL, automatically for lateral ankle sprains, and occasionally the deltoid. That's a lot trickier, as we'll see later in the presentation. For tendons, usually it's the peroneal tendons. You can strain those with a lateral or an inversion event, but you can have avulsions at the base of the fifth. And then oftentimes I will look at the tibialis posterior tendon if I have some concern for insufficiency or acute injury there, as well as the other tendons in the tarsal tunnel. So for the metatarsal bases, the primary one we think about clinically is the fifth, especially with lateral lateral foot pain. And so my technique is to find the peroneus brevis on its long axis and then just follow it to the insertion at the base of the fifth metatarsal. Like most tendons in the foot, the tendon tends to fan out as it inserts on its respective bone. But here I'm looking for any pathology within the tendon, whether that's the mid portion of the tendon or the insertion of the tendon. And of course, avulsion fragments should be detectable on ultrasound. And then the other thing in terms of bones I look at is just being able to identify the first and the second metatarsal bones, because those become important when you are assessing the Lisfranc ligament. For the talar dome, I like this because if you're going to do a comprehensive evaluation of the ankle, this is a great starting point, and you can get this image here. And I did forget to mention, these are all my images. These are not borrowed. So this is the talar dome, and you can see the hyaline cartilage and echogenicity across the entire talar dome, as well as you get a full full scope view of the primary tendons in this area. So going from medial to lateral, it's tibialis anterior, typically the extensor hallucis longus, and then the extensor digitorum longus. And oftentimes the dorsalis pedis is quite pulsatile, depending on which system you're using. You can see that in high definition and differentiate that between the vein as well as the nerve that are running in the same area. And so while I'm in this view, if there's an effusion present, you're likely to see it. That's not the primary way that I assess for ankle effusion. But you could also see, depending on age and mechanism of injury, maybe a hyaline cartilage defect. Ultrasound's not incredibly sensitive for that, but it is worth kind of scanning and translating the probe back and forth. And here would be the position typically that I would get this home view in. For the tibial talar joint, I apologize. This is a long axis image, but the example here is still short axis. So what you would get on the long axis view is a nice view of the joint recess running between the tibia and the talus, as well as, depending on where your probe placement is, some dorsalis pedis artery running above it. I like to identify the dorsalis pedis artery if I'm thinking about any interventions in this area for obvious reasons. I would want to clear that out of my scope of view before I consider aspirating or injecting the tibio-talar joint. So approach here would be long axis to the tibia and translate the probe inferiorly or distally until you're able to see the talus. When scanning the midfoot, I find that it's hard to know exactly which tarsal bone you're looking at times. I think I kind of march myself down, going proximal to distal, so I know that the tibia should be the first bone that I see, followed by the talus and then the navicular. But another way would be to just identify that very prominent hyaline cartilage there on the talar dome. And of course, you have a fat pad that with an effusion will be pushed up. Sometimes you can see a loose body in there as well. For the peroneal tendons, this is actually not a great depiction. I'm sorry, guys. Usually you go lateral malleolus with a more vertically oriented probe to try to capture the cortex of the lateral malleolus as well as the peroneal tendons on short axis. Of course, everyone's anatomy is different. Sometimes you will see the differentiation and separate sheaths of the peroneal tendons. However, in most cases, if you're at the level of the malleolus, you will see two separate sheaths. So identifying brevis and longus in this orientation, I don't think is incredibly important. You know, if you have additional imaging that says one is injured or pathologic versus the other, then maybe this is probably not how you want to inject these tendons anyway. But it's more about identifying these in short axis, being able to rotate your probe and then trace it down to either the base of the fifth or down to the arch of the foot for longest. My watch is going on. In the medial aspect of the ankle, the tarsal tunnel is another great kind of global view. And, you know, I did kind of crop two separate images because it's very difficult to get all of the tendons with the right echogenicity. Because when you wag your probe, you lose one and gain another. So this is kind of a superimposed image from the same ankle. But the home base here would be, and this is more or less what I wanted to show for the lateral aspect. I apologize again, but closest to the medial malleolus, you have tibialis posterior. Then you have flexor digitorum longus. You have your neurovascular structures with the pulsating tibial artery or posterior tibial artery and the posterior tibial vein, as well as this is a good view of the tibial nerve there hanging out in that same anatomic area. And very deep and very out of the way is the flexor hallucis longus. And so being able to see and identify these tendons on their short axis with one probe orientation allows you to pick and choose which ones you want to trace and follow on long axis to the respective insertions, look for fluid around the sheath, etc. And then if you're ever not sure, or, you know, oftentimes when you're looking at this part of the ankle, you will not actually see the flexor hallucis longus because of the anechogenicity and the anisotropy, then you can passively move the big toe. I think it becomes a lot easier to differentiate that way. For the ATFL, again, probably the most common thing I look at for most of my patients. This is easily seen when you find the lateral malleolus and you basically anchor the probe proximally and rotate the probe until you're able to pick up on the talus. Again, a helpful tip would be to look for that hyaline cartilage in the talus, but with a bad lateral ankle injury or chronic ankle instability, a lot of the times this ligament is already shot, and so it becomes harder to appreciate. And so if you're confident in your methodology and you can't pick up this tendon, this ligament, then they might already have a chronic rupture or an acute rupture. And a lot of times in the acute setting, you'll see a lot of surrounding edema and hyperechogenicity there. So again, I start at the lateral mal, then I just rotate the probe until that talus and its cartilage are visible. And then I'm looking for that usually relatively hypoechoic structure that's bridging that gap there. So this would be the lateral malleolus and the talus over here in this image. The calcaneofibular ligament is a different orientation. You know, people talk about the numbers on the clock and trying to systematically go about the lateral ankle. I think that becomes confusing, but maybe that's just me, because depending on which foot you're looking at, the numbers change. At any rate, when you're looking at the ATFL, it's much more horizontally and parallel to the metatarsals. And when you're looking at the CFL, it's much more vertically. So what I do is I try to find the peroneal tendons again on short axis. Sometimes it becomes an oblique axis. You can see here that these are not perfect short axis images of the peroneal tendons, but what I'm trying to identify is a structure that runs deep to them and is going from the lateral malleolus. So the best way to I find to appreciate the CFL is actually to do a little bit of a dynamic scan. So once you get this image more or less on your monitor, you can have them slowly, because of the bony architecture in this area, slowly dorsiflex and plantarflex. And what you'll see is this ligament becomes taut and lax as they move the ankle. and that will result in the peroneal tendons moving up and down. So in this way, it sort of presents like a hammock or a sling. And once you see that, then you're able to really identify the CFL. And if there's not much movement with that passive dorsiflexion and plantar flexion, then maybe they do have a CFL rupture. As far as the syndesmosis, I don't typically look for the posterior inferior tibiofibular ligament. However, you can do that. I think most commonly I look in the anterior aspect of things. And what I'm looking for is, and honestly, we're just going to move this right now in real time. What I'm looking for is this type of placement. And so it's not as horizontal as you might think. You're thinking back to the Netter textbook days. You want to identify the lateral malleolus first, and then keep rotating your probe again until you see the tibia. Now, one point that can be a source of confusion is if you mistake the tibia for the talus or vice versa. So again, just use your knowledge of anatomy. If you're not sure, just keep coming proximally. Keep rotating that that medial aspect of the probe more superior and more superior, and then you'll definitely get the talus out of the way. But you're looking for another ligamentous appearing structure that spans the anterior and superficial aspect of the fibula and the tibia. Another nice thing to do here, if you don't see it, is to do a dynamic Hopkins squeeze test, and that will give you some knowledge of the laxity or relative laxity of that ligament. Moving on to the deltoid before we finish up with the Lisfranc. This one's tough. The deltoid has a high architectural structure. Certain components are more clinically relevant than others. When I am assessing for a deltoid ligament sprain, I think a lot of us in our field, if we're concerned about it, if it's an unstable exam, they're unable to bear weight, we're probably going to proceed with an MRI if resources permit. However, if you're comfortable with it, going on the medial aspect of the foot can allow for a pretty good deltoid ligament evaluation. So again, it's about anchoring and rotating. That's the theme here. So I anchor on the medial malleolus and rotate until I can see the navicular bone. That is one of the more commonly injured. And so here we go here with this probe orientation and the medial malleolus. You can see that the navicular bone, which typically with this orientation is more, it comes up more superficially than the talus, so that you don't confuse those two. And then we see this band structure here. That would be the tibionavicular portion of the deltoid. Another one I like to look at, and in this pictogram here would be number 4, but this is the tibiocalcaneal ligament of the deltoid. Again, what I like about this is if the anatomy and the foundational anatomy that you have as a clinician, fellow, resident is sound, all you're doing is looking at bones and trying to find the connection between them. So it becomes much easier when you just take the entire picture out of it and just recognize that you're looking in this view for the tibia as well as the sustentaculum, which is part of the calcaneus. So here on this side, pretty vertical orientation. You can see, like I mentioned, number 4 in the pictogram there, you have the tibia. You're probably not going to see the calcaneus because it's such a vertically tall bone, but what you will see if you're in this region is a very thin band that will eventually go to the most superficial part of the calcaneus in this region, which is the sustentaculum. We'll see that again in a second. Spring ligament. I don't know why I think this has a fun name, but this one's a really tough one to evaluate. Again, probably going to be picked up 9 times out of 10 on MRI versus ultrasound, but for comprehensive and completeness sake, I did want to show this in this presentation. So the spring ligament of the deltoid goes from the calcaneus to the navicular bone, and in two important parts. So it's really the sustentaculum again that's involved here. So going back to my approach, once I'm happy and confident that I have the sustentaculum in view, then I do an essentially 90-degree rotation to get from this perspective to this perspective, and try to identify the banding bridge, ligamentous bridge that goes from the sustentaculum to the more superficial navicular bone. And I tried really hard to get a good picture of it. This was the best I can do. Again, I said this is a tough ligament to identify, but you can sort of appreciate a structure that comes here. And then eventually we'll go to the sustentaculum, which is outside this picture. And now for the case. So the Lisfranc ligament, when I was going through my first year of fellowship, I said, when am I ever going to look at this? This is tough. But we do have really high resolution ultrasounds available to us. So I started to practice and I started to think about it. And the more I practiced, the more simple it became. So I did want to just reference that the Lisfranc ligament is a complex. It has multiple different ligaments, such as the deltoid, but the most easiest to assess and oftentimes the most commonly injured is that dorsal aspect of the Lisfranc. So I know it's a small photo, but that Lisfranc component that is typically evaluated really runs from the base of the second metatarsal over to the medial cuneiform. And so, you know, it's an odd oblique positioning, so it's not straightforward, but what a simple approach might be to, you know, find the shaft of the first metatarsal on long axis, trace it down to the joint space with the tarsals there, feel confident that you have the medial cuneiform, and then just rotate your probe until your base of the first falls out of view, and then you get the base of the second. I think that's tougher than doing it the opposite way, which would be to find the base of the second metatarsal and then orient your probe, rotate that proximal end until you lose the intermediate cuneiform and hit the medial. So I have a video in here. It should play, but you know, it's a nice thing to practice. So you basically are translating your probe until the bones fall out of view, and then the next one that you pick up, if you're rotating slowly, is going to be the one that you want, if that makes any sense. So for instance, when I'm looking for the second metatarsal, I will start over the first and translate the probe until I see soft tissue and no cortex, and keep translating until I finally see the cortex and the shaft of the second, trace that down to the base and the articulation, and then angle the probe. So this is this view was obtained from this sort of orientation, and in some folks, the transducer is going to be even a little more angulated than that, but that is that this is more or less what you're going to see. So over here, it's not labeled. I apologize. This is the second metatarsal, and then here we're having the base of it here with the joint dropping off, picking up the medial cuneiform over here, and it's a pretty tight band structure here. This is a normal Lisfranc ligament, so we can see it's uniform in echo texture. I know it's a little blurry, but there's no problems here. There's no edema around it. And then this is the case. So I had to use a different ultrasound for this case, but again, a very similar picture to the quote unquote normal I just showed you. And so here on this side of things is the base of the second metatarsal. I do have my probe oriented more or less in this plane. And here would be the medial cuneiform. And so when I was evaluating this patient in clinic, I had a lot more clinical information. I knew she was very tender in that exact area. I also did, a stability test where I kind of held the plantar and dorsal aspects of the respective metatarsal bases and applied translational force. One, to see if that was painful, and two, to see if it seemed a little bit more lax than the contralateral side. But here you don't see the tight band. It's lost in a lot of anechogenicity here, which is likely due to edema, possibly a little bit of a hemorrhage there, hematoma. But when I saw this and I did a little bit of dynamic assessment, I did start to question the Lisfranc ligament. Here's another video of me just kind of tracing it back. Again, I wish I done this again, I would show the tracing going from the second to the intermediate and then finally to the medial, because I think it's easier to show than to tell. But there you go with the scanning, and this is translation. That's the movement that the probe is doing here. So I'm just kind of gently translating back and forth. It's a very small ligament, very fine structure. I used a high frequency probe for this, so it has a very small footprint. And I was just trying to convince myself that there was ligamentous tissue there, and I can never see it. A little bit more blown up view here. And so finally, with that suspicion, I did have her undergo an MRI, which showed a complete rupture of the dorsal aspect of the Lisfranc complex, and sent her to a colleague of mine in foot and ankle surgery. He did some stress views, was not happy with the shift that he saw with a little bit of stress, and she eventually underwent open reduction internal fixation of that structure, and is doing well as far as I can tell from the medical records. So that brings us right up to the 30-minute mark. I'm happy to stay on for any questions.
All right. Well, thank you, Shane, for that presentation. For the report for this case, then you ended up calling it as a complete Lisfranc tear.
Yeah, that was supposed to be in the presentation.
Okay.
Yeah, so what I wrote, and I'm of the mindset where when you document your ultrasound findings, it should read similar to an MRI. So I'm not giving clinical diagnosis, I'm giving appearance. And so for her case, what I read was no cortical irregularity or avulsion fragments at the articular surface of the tarsal metatarsal junction. And I said there is no there appears to be disruption of the dorsal Lisfranc ligament with increased laxity on dynamic translation of the base of the metatarsals, and increased anechogenicity in the tarsal metatarsal junction. So that's how that read.
Perfect. Yeah, I think sometimes, obviously, with that report, that's helpful. Just kind of figure out a good way to kind of word it, especially for the official ultrasound report that you'll provide. So, well, listen, just yeah, a few comments to make and a few things that you had already kind of touched on. Yeah, as you had mentioned with the Lisfranc being a ligament complex, there's different parts of that complex. With it being dorsal, interosseous, and plantar. And the one main area that we can really focus on with the ultrasound, of course, is going to be the dorsal aspect of that ligament complex, which is usually the most frequently injured. And obviously, I know usually we're not thinking about looking at this, commonly with ultrasound, but as you showed, It's a very easy ligament that you can start to visualize, with a set protocol and just remembering the bones in that area, and then just really kind of getting into that oblique angulation, I think is really the kind of key, for this, and just getting kind of a set protocol to be able to go ahead and find it and just familiarize yourself with taking a look at this. A couple other things, for these areas that you don't commonly scan as much, especially some of these kind of small, compact ligaments. It's always important to kind of do that dynamic evaluation, because at first, as you had mentioned, you can start to think, am I seeing the ligament there, or is that a complete rupture? So doing dynamic evaluation, I think, usually can be very helpful. For this, I don't know if there's like a set protocol that everyone does dynamically for this, but obviously you can do, ankle dorsiflexion, plantar flexion. You can do inversion, eversion movement, as well too. And then of course, for some patients, you can have them weight bear. And then that may demonstrate, widening of that area. The other key for this that I think is usually helpful is you can do a simple side-to-side comparison. So if this is in an area that you're taking a look at frequently, doing a side-to-side comparison, especially if this is your first or second time, usually that can make it very apparent. And then just some of the other secondary findings that you had mentioned, that you in your report, was just looking for any, avulsions or any joint abnormalities, in that area of fusion, which would just be secondary signs that, hey, there may be a ligament, injury at this location. As far as the protocol goes for this area, it's tough. There's nothing, really standardized. So that's where these presentations are really helpful. Usually these are fairly high trauma, and so you can include a lot of the structures, as you had mentioned, taking a look at other ankle ligamentous injuries. I think when you're just, focusing on the midfoot area, main thing is just, assessing those midfoot joints as well as the tarsometatarsal joints. Some of the important, ligaments in the area that you had mentioned are going to be the talonavicular. You can also be looking at the bifurcate ligament, dorsocalcaneocuboid ligaments. And then once we really kind of get into that tarsometatarsal area, there's obviously ligaments for each of the metatarsals in that area, as well as inner metatarsal ligaments as well too, that could be injured. But obviously, for each of those, I think, trying to correlate that with your clinical examination and exactly where the patient is having pain at can be helpful, because otherwise this can be an area where you can start to get pretty extensive with your protocol. And so I think just making sure, once again, kind of focusing it with your clinical examination as well too, can be really helpful. And so those are some of the kind of comments I wanted to make, but we'll open up for any other comments or questions from anyone else on.
Yeah, this is Doug Hoffman. Shane, thanks for the presentation. Um, I kind of put the Lisfranc ligament in the same category as the dorsal scaphoidal ligament, and in some respects, the anterior inferior tibiofibular ligament, in that it, first of all, it's a multi-layered ligament. And so we are seeing obviously the superficial layer, but presume that if it's torn, then we have a complete tear. I know that's true for the dorsal scaphoidal ligament. Actually, I don't know if that's completely true for the Lisfranc ligament. But one of the analogies with these ligaments is that we can see them really well on ultrasound and we can stress the area. However, for Lisfranc's ligament, for the dorsal scaphoidal ligament, and for the syndesmosis, we don't really have research to tell us what's abnormal and not. And so, in my experience, one of the advantages of seeing this Lisfranc ligament is, in your case, identifying unsuspected injury, but also being able to stress a ligamentous injury at Lisfranc's joint and not necessarily a fracture dislocation. And we're not sure what to do with that. And so, our foot and ankle surgeons, him and Haw, sometimes when we're at 2 millimeters, let's say, and well, it is unstable, but how unstable is it? Is it worth a operation or not? And so I think, one of the values is to identify the fact that we can see these and we do need more research because it could be quite valuable in these three areas, including the syndesmosis, is to stress these areas and have some standardization saying, well, we know these people probably going to go on and not do well. Or if it's under this amount, then we're probably fine. And then one other just comment about the Lisfranc ligament. It's a useful area because, with a little practice, as you point out, Shane, you can find it. It's also a nice area to see the deep fibular nerve. Sometimes it can be difficult to see the deep fibular nerve in the midfoot area after it leaves the ankle region, but it's usually more conspicuous right over Lisfranc's ligament, and then trace it backwards. Let's say you're looking for a neuroma of the midfoot. So I found that a useful landmark.
Oh, so you use the Lisfranc to help identify the deep peroneal.
Yeah,
Interesting.
yeah.
Interesting.
I just find it a little more conspicuous there if I have trouble finding it in the midfoot region, and then trace it backwards if I need to.
Yeah, I mean those are excellent points, and that's what I always preach to the residents who are considering sports medicine or learning ultrasound is that there is no substitute for the imaging under manipulation. And most of the time it is stress, valgus, varus, but you can actually appreciate what the tissues are doing under duress and kind of simulate too. You can ask a patient with ulnar nerve subluxation symptoms, for example, do that thing that makes your nerve move. And it doesn't have to be exactly flexion and extension of the elbow. They can kind of replicate that snapping hip syndrome. So that's one of the main reasons that I use ultrasound in my practice.
Yeah. Do you, Shane, do you or Stephen Brennan, do you stress this area with just a full standing, or do you do something else when stressing the Lisfranc joint?
I'll go for with this case specifically. I don't know if there's any great special tests with eponyms, but I kind of held her second. I grabbed around because she was 16, had a little foot, and kind of held the majority of her foot in one hand and stabilized the second, and then kind of, in a way, held a probe with that hand. It was kind of funky, was not perfect, but then I grabbed the other hand and tried to move the first metatarsal base, and I did see some movement there, and again, just not being able to pick up the ligament that I know is there anatomically on ultrasound was ultimately what led to my suspicion for it.
Doug, this is Brennan. Shane, nice work on this presentation. One of the things I'll do two stress maneuvers, Doug. One is that with my hand that's on the side of the first metatarsal, I'll anchor like my small finger, ring finger, and like thenar eminence on the metatarsal, and then I'll hold the transducer with like my the tip of my thumb and forefinger across the Lisfranc joint, and so that M2C1 kind of orientation. And then I'll hold the second metatarsal with my other hand and kind of the forefoot, and I'll do like a kind of like a shucking maneuver, like Shane described. I find that by kind of anchoring on the first with my hand, I can hold the transducer in a nice locked position while I do that stress maneuver. And then the second one is I'll do standing, and both of those I always do with a contralateral comparison. And I think I've seen one paper that suggested maybe like 2.5 millimeters of diastasis would be supportive of a unstable Lisfranc injury with dynamic ultrasound. And I think I believe that was standing, if I remember right. And so that's kind of like in my head what I look at um, is the thing I'm looking for from a like a quote unquote value standpoint. But really subjectively, I think if you just see a ton of movement and you see any splaying, then I'm really concerned about it.
So you're saying that it's the difference between the non-stress and the stress maneuver, 2.5 millimeters, that is your cutoff. Understanding that it's not validated, and obviously if it's loose, then it's unstable. But you're saying it's the difference between the stress and non-stress,
Yeah, it
not just
is.
diastasis between.
Yeah, if I remember right, I think it's a stress delta. I'd have to look. I see this injury infrequently enough that I look back at the paper when I do the stress maneuvers just to double check. But I'm
Mhm.
pretty sure it's that stress delta.
Yeah. Uh-huh.
Yeah, and I think that's, quote me if I'm wrong, I think that's consistent with the interval for diastasis on standing films too, or standing AP. I think it's 2 millimeters, so that would make sense.
All right. Well, unless there's any other questions or comments, we'll go ahead and conclude today's presentation. So once again, thank you very much for the presentation. We'll have one more in 2 weeks, which will conclude the fellow presentation for this year.
Thank you guys so much for the invitation, and thank you for joining.